Hello, I'm Dr. Carren, ENT surgeon from Hospital Sungai Buloh. My topic today is balancing the unsteady through VRT. But before I begin, I would like to thank the organizers for having me today and to share some of my knowledge, especially on VRT. So what is VRT? VRT is vestibular rehab therapy or rehabilitation therapy. My presentation today will involve 6 parts. So these are the slides which will be coming up. All right, so we'll begin with what is VRT? What is vestibular rehab therapy? And why do you as an audiologist need to know this stuff, right? So the American Speech Language Hearing Association says that the role of audiologists actually is within their scope of practice to treat patients with vestibular disorders, including canal repositioning procedures, which I think Ms. Asrin has presented this morning, as well as consultation with or serving as a member of the multidisciplinary team managing patients with balance disorders or with dizziness. Right. Typically, we expect the physiotherapists or occupational therapists to provide the therapy, but in actual fact, an audiologist can also give therapy. This is also supported by the American Academy of Audiology, which says that audiologists can carry out treatment and rehabilitation for impairments of vestibular function. But I think in Malaysia, it really depends on the audiologist as well as the center, whether they're confident enough to proceed with therapy. Similarly, in Canada, they also think that audiologists are the ones who do treat patients with vestibular problems, not only the physiotherapists. So back to the question, why do you need to pay attention to this class or this lecture? So managing vestibular patients often requires a multidisciplinary team. So it begins with a doctor, could be a neurologist, can be an ENT, can be a primary physician. And then we would send to an audiologist for testing to assess the vestibular function. And after that, treatment is either by the physiotherapist or the physician. But in this case, audiologists can also give, or an audiologist who understands the treatment protocol can help with patient education and continue to encourage the patient to be compliant to the therapy. So depending on regions, parts of Malaysia, and I know there are some audiologists who oversee VRTs. Okay, there are also some therapies which can be performed using the equipment that's already in your lab. And this one I'll present later in the slides. So what is VRT? VRT is a widely accepted and popular strategy for managing patients with vertigo. Okay, it's an exercise-based method, so no medication involved, aiming to maximize central nervous system compensation at vestibular nuclear and other CNS levels for vestibular pathology. The earliest VRT we all know is called Cotton-Cooksey's exercises. It's actually developed by a surgeon and a physiotherapist to treat patients with labyrinthine injury, which result from surgery or head injury. They found that exercises designed to encourage head movements or eye movements hasten or fasten the patient's recovery. And since then, it's been used a lot in peripheral vestibular disorders. So what are the principles of VRT? Right, we have number one, adaptation, where it involves readjusting the gain of VOR or vestibular spinal reflexes. I think this one, the audiologist understands all about the gain of VOR, especially that's what you report in your test, right? Then we have substitution, is where you employ alternative strategies to replace the lost vestibular function using visual and somatosensory cues. All right, how we compare this is in adaptation, we have some amount of residual vestibular function. And the principles of VRT is to improve whatever function or vestibular function we still have. Whereas in substitution, we are using the other organs to help you achieve balance, such as your visual or your somatosensory. Right. The third method is habituation, where the use of repeated head and visual movement activities is used to reduce the symptoms provoked by specific movement to produce desensitization. So in this case, it is not to replace, it is not to improve a function, but it is movements which make you feel less uncomfortable. Okay, so it's all part of desensitization. So when we put in all three of these principles together and the patient starts to feel better, then we use the term things like compensation, or the patient is compensated. If they're well compensated, it's used to describe fully functional recovery. They can function as normal, while poorly compensated is applied to describe partial recovery. And then sometimes you may hear the term decompensation, where it's adopted to describe a near total relapse, meaning they've gotten better. And then for some reason, could be because of an illness or lack of sleep or medication, they may have decompensation, where there is near total relapse of their symptoms. So indications for VRT. Okay, we see it's very useful in stable vestibular lesions, meaning that there is no evidence of progressive process with an incomplete compensation, meaning they have not recovered after the insult. If it's a lesion which is progressing, vestibular rehab will not help, okay, because the condition is still evolving. Yeah. It's also useful in central lesions or mixed central and peripheral lesions. So it could be a stroke, could be a head injury, but the prognosis is likely to be more limited. It's not as good as for a solely vestibular peripheral lesion. Patients with head injury, it can recover or can be helped with VRT because they would have some amount of imbalance problems. Psychogenic vertigo. Patients sometimes need not have hypofunctioning vestibular system, meaning one side is hypofunctioning, but it could be due to depression or anxiety, and VRT has been shown to be effective. Elderly with dizziness, those with presbystasis, VRT helps. Okay, it's very important to help prevent falls, as we know that falls is actually a major problem of morbidity in the elderly. Vertigo with uncertain etiology. Sometimes we get patients where they have persistent dizziness and we don't really know what is the cause. Everything else may be normal. VRT can help. BPPV, again, going back to what Ms. Azrin has said, BPPV can be helped with repositioning maneuvers. But sometimes after the repositioning, they get this lingering dizziness or heavy-headed feeling, and that's where VRT is helpful. VRT is effective in improving functional deficits and subjective symptoms resulting from unilateral or bilateral peripheral vestibular hypofunction, as well as from central balance disorders. So when we compare patients with unilateral or bilateral vestibular loss, those with unilateral vestibular loss have better prognosis compared to those bilateral vestibular loss. VRT have its limitation. Similarly, between peripheral vestibular dysfunction versus central vestibular dysfunction, those with peripheral vestibular dysfunction respond better to VRT. So what are the types of VRT program available? Okay, how do we decide on the types of VRT programs for the patient? So it depends on the individual clinical history, which is very, very important, because you need a diagnosis, right? Then it's examination, bedside testings, vestibular testings, including imaging when it's indicated. Yeah. So why we go through all this, which sometimes can take an hour plus or even more. Actually, with the vestibular testing, it can take up to 2 hours. This is to identify the diagnosis, okay? To identify the functional losses, meaning they may have a diagnosis of an infarct, but the functional loss may be more than that, right? And then by knowing the diagnosis as well as the functional losses, we can determine the goal of the therapy for VRT. So using the evaluation results, the therapists, such as yourself, may develop an individualized treatment plan. Typically, design protocols are therapist-directed and patient-motivated, beginning at the minimal skill level that the patient is capable of performing. So you start at the easiest level they can do, all right? Then they go home and they have to practice until it becomes too easy and we make it more difficult after that. So the complexity is increased as compensation and habituation occurs until optimal balance is attained. So at each visit, the therapist reassesses the patient's progress and adjusts the protocol as necessary to provide gradually increasing complexity of tasks and to continue challenging the patient and encouraging them to progress. So again, if you as an audiologist is not overseeing the treatment, What you can do is, if you regularly see them back again, can encourage them to continue to do the exercise, to push themselves so that they stick to the program. Because if you don't do it, you will not get better. So how do you know whether they're getting better or not? So you need assessment tools. So these assessment tools measures for symptomology, the symptoms they have, self-perceived handicap. Handicap means things they cannot do or they're unable to do as compared to previously, and the quality of life. So there are many, many forms available. Okay, they're all validated forms. But in Sungai Buloh, what we use is this dizziness handicap inventory, Eurocall for this quality of life, and DAS scorings. Okay, DAS, which is a depression, anxiety, stress scales. Because I think we do see patients with chronic dizziness, and after a while, you find that the dizziness creates stress for them, and the stress over time will create the dizziness for them also. So we need to know how they are progressing in terms of the dizziness as well as the emotional and mental aspects of the illness. So assessment of functional skills, here again, there are many bedside tests where we can do, but it's also limited by how much time you have, how much space you have. Yeah, there are many, many tests. And here I see, I've actually indicated down here, you have a few websites you can refer to. We have this Shirley Ryan Ability Lab, which tells you how the tests are done, what is the normal range, what's abnormal range, as well as physiopedia.com. So the types of VRT program, I think the ones you may be most familiar with is the supervised customized program, right? So if you send a patient to the physiotherapist for vestibular rehab therapy, it's considered a supervised customized program. The physiotherapist will oversee or supervise the exercises, and they will design the exercise to suit the patient's ability or interest or what they can do or not, all right? They will teach them, and then the patients have to go home and practice it. And then they have another appointment, maybe once a week, or if it's private, it's once a week or a few days once. But if in the public side or government side, sometimes it's maybe once a month. So the patient has to do it at home. All right. Then you have the self-guided, non-customized home-based program. The original Cotton Cooksey exercises is this example. Okay. They are given a sheet of paper with the exercises they're supposed to do, and they have to do it. Okay, do it at home every day, a few times a day for a certain number of time. It doesn't matter if it's making the patients uncomfortable or they're having problems doing it, they just do it. Okay, it works, but may not be as good as a supervised customized program. All right, that's why now we have the third type, which is a customized home-based program. Because as you know, there are patients who come very far away to come to the hospital, yeah, or the physiotherapist is so busy they can't see the patient once a week, which is the best, right? So what they do is they can customize certain exercises to suit them, and they go home and they do it on their own, and they guide themselves. Meaning you can tell them, all right, based on this chart or this program, you can do part 1, part 2 first. If you find that you have no problem doing it, please progress to part 3 on your own. Then I'll see you back again in a month's time. Yeah. So what are the goals of VRT? All right. So first, we want to enhance gaze stability. What is gaze stability? Meaning you want to keep the eyes stable, okay, so that the vision or the image falls on the retina well. It doesn't shake, it doesn't move, it's not out of place. Okay. Then we want to enhance postural stability. Keep them from falling, keep them stable in the body wise. Of course, we want to improve their vertigo. Patients complaints, they're feeling the dizziness or the swaying, they want to feel better. And lastly, we want to improve this daily living activities so that they can go back to doing what they can do before the illness. So this is the 4 main goals of VRT. How do we achieve that? Okay, so we can, one of the methods is through adaptation. So adaptation exercise has the goal of improving the gain of vestibular ocular reflex. So I think as audiologists, you all know what are the gain, right? So we want to reduce the slippage of visual images on the retina with each head movement, all right? So that the image is on the retina at the fovea as accurately as possible, all right? We also want, we can also help by doing through habituation. Habituation exercise are the use of repeated head and visual movements or those activities to facilitate reduction in the symptoms provoked by specific movement. So for example, some patients may say, I cannot stand turning my head like this all the time. Okay, so this makes them feel dizzy. But if they were to do this persistently, many times a day, after a while, the symptoms may not disturb them so much. They may not feel dizzy that much. It's a form of desensitization. Okay, so that's habituation exercises. Then we have balance and gait exercises. This is targeted to improve in both static and dynamic balance ability, together with overall improvement in gait under a variety of environmental conditions, so that they can walk again, they can move again, they can go out of the house, yeah, without the fear of falling down. All right. And we also would like to help with general conditioning exercises to maintain an active lifestyle, right? So that they can maintain the compensation process. So how do we enhance gaze stability? Okay, so gaze instability is seen in patients with especially vestibular hypofunction, right? Because of the imbalance, all right, then you cannot maintain the gaze stability. And how we improve it is through vestibular adaptation, where we want to decrease the gain of the vestibular response to the head movement. So the eye move is actually quite stable, even though the head is moving. All right. So the best stimulus for increasing the gain of vestibular response is the error signal induced by retinal slip, which is the image motion on the retina during head motion. Okay, let me give you an example. If you are sitting on a bumpy bus or in a car and you're reading your Facebook messages, right? The image in your head is actually quite stable. You can read it quite clearly because your vestibular ocular reflexes are working very well. Okay, it can stabilize the image. All right, but in patients where you have vestibular hypofunction, where one side is not working equally as the other side, you find that the image jumps and they find it very dizzying. They cannot read. Okay, but the treatment is actually to keep causing this retinal slip. These exercises which cause the retinal slip, it will help the brain repair on itself. All right, then you can have vestibular adaptation. So how can we do that? All right. So one of the more common exercises we do is called VOR times 1, where the retinal slip can be induced by horizontal or vertical head movements while maintaining on a visual fixation on a target. So in this case, the easiest is to visualize your thumbs, like in this picture, where my audiologist Encik Asmi has gladly volunteered to be my model today. So the target can be either you holding a card, or you can just hold out your arm's length, or you see a poster across the room. Okay, look at that image or your thumb and repeat moving the head, such as this. All right, head movements should be at about 2 hertz. All right, 2 hertz means 2 turns every second, while the eye must focus on the thumbs. Okay, so some patients I find if they have neck stiffness or the shoulder is aching, just look for a poster across the wall, look at that and just shake the head. All right, do that for about 5 minutes a day or as many times as you can. The more you do, the longer you do it, the faster you'll get better. All right, so again, the most effective movements is horizontal and vertical movements. Okay, this doesn't work much because they find that the image doesn't slip as much. Okay, so once the patient says that I no longer feel dizzy, I have no problems focusing on my thumb, you can go on to the second level, which is VOR times 2. Okay, so it's actually called VOR times 2. Yeah, so this adds in a smooth pursuit element to the exercise so that your head and the eye must move at the same time. Okay, like this. So the eye always focuses on the thumb. Move the head and the hand in opposite direction. Okay, this forces the eyes to move also, and that gives you the smooth pursuit element. All right, again, they should perform the exercises for gaze stability 4 to 5 times daily for a total of 20 to 40 minutes a day, in addition to 20 minutes of balance and gait exercises. So during the exercise, it's good to induce retinal sleep. So to induce that, you need to be in a bright room, right? Curtains are open so that they can focus better. So how do gaze stabilization exercise work? It helps with substitution by other eye movement systems. All right, so saccade modification, smooth pursuit enhancement. So you need to remember that saccade and smooth pursuit is actually controlled centrally by the brain. It's not a reflex. So the more you do, the brain can retrain for that. Okay. There's also an element of central pre-programming. So if you do an exercise where your eye can predict its location, then it can pinpoint better. All right. So doing one exercise such as this. So you look at just the eye move to look at this thumb and then look at this thumb. So the eye move left and right, left and right, left and right. In the beginning, they may not be able to reach the point of this thumb, but the more they do, their precision improves, and that is your central pre-programming. Okay. So that is for enhancing gaze stabilization. Now we move on to enhancing postural stability. Okay. So postural stability recovery is slower than gaze stability recovery, right? But it doesn't mean that it will not, just that it takes longer time. So the primary mechanism of postural recovery are increasing reliance on the visual and somatosensory cues through substitution. So if you feel like your body is not going to be very stable, maybe because of a vestibular event, the brain automatically uses its other organs or system to help you become stable. All right. So one way is through visually, use your eyes to focus. And next is somatosensory cues, meaning from your joints, from your touch, from your feet, where you're standing, right? All that give you information to keep you balanced, keep you upright, prevent you from falling down. All right. And then also exercises which involves you to rely back on vestibular responses will help with adaptation. So the goals of VRT to help patients in postural stability is to learn to use stable visual references and surface somatosensory information for their primary postural sensory system. We also want them to use the remaining vestibular function. That means don't just rely on visual references, but to use back its vestibular function. Okay. We also want them to identify efficient and effective alternative postural movement strategies, especially to prevent falls, and also to recover normal postural strategies. So substitution by vision and somatosensory cues happens automatically. Okay, the brain will automatically use vision and somatosensory cues to keep someone balanced, especially after they have suffered from an incident which makes them burning or makes them have a vertigo attack, right? So although visual cues are important, they can be very destabilizing as a postural reference, okay? Because what happens is now they use their eyes to look at something to keep them stable, all right? But if what they are using is moving and swaying, their body will also align to it. Okay? Because now they use its vision to keep them stable. And this phenomenon is called visual dependency. Patients now may complain of feeling dizzy in crowded or visually stimulating areas. So you will notice that after maybe a week from vestibular neuritis, they may not have the true spinning vertigo anymore, but they will start complaining that I cannot stand going out to a crowded shopping area. Okay, because when there are a lot of people moving, I will start to feel dizzy. Okay, what is happening is now there's so many things moving around, they cannot focus on a point to keep them stable. So they find it very disturbing. All right. It's also disturbing to patients who are visually dependent. So such as this lady here in my picture, okay? If she uses the train as her stable point, okay? And the train starts moving, she may suddenly feel like she's falling off. And if she's standing too near the edge of the train track, she can actually fall down or into the tracks, which becomes very dangerous. All right. So therefore, it is not good to foster visual dependency. Okay, so if someone comes to you already having visual dependency, meaning they find that they can, at the end of the day, they feel like their eyes are very tired, they cannot stand areas which are very crowded, yeah, they cannot stand things which are moving a lot, they cannot look at the traffic where cars are moving, they need exercises to break off this visual dependency. How do we do it? We give them even more visual stimulation. Sounds very evil, but that is the treatment for visual dependency. All right. So one example is you can use this disco ball method. You have a light shining and the disco ball actually turns and spins and the light around the room will spin. All right. it will be very disturbing for these patients. But if they can sit in it for 15 minutes, after a while, they actually develop habituation. They feel it doesn't disturb them as much. All right. So first they can start with just sitting. And then after that, they need to stand up and try and maintain balance. So if you don't have this disco ball, you can actually use your optokinetic lines which you have in your lab, right? If you want them to practice this at home, they can use stripy curtains at home. Or in this case, I normally ask them to practice their VOR in front of the TV. Okay, example like this. So you need to stare at the thumb. Okay, you need to stare at your thumb, move the head left and right, focus on the thumb with a disturbing background. The more movement, the better it is. All right, let's try again. So all of you try and look at the thumb. Let's see whether the background disturbs you. Okay, those with visual dependency will feel very disturbed. Okay, so they need to do these exercises regularly so that it doesn't disturb them anymore. So how about somatosensory dependency, where I say now they use their feet on the ground to feel stability, to enhance their stability. All right. This dependency is actually useful in patients with bilateral vestibular deficit. Okay, they really need that to keep them stable. Okay, but if we want them to go back to normal and not depend on other senses, they need to do exercises which does not allow them to feel the ground. All right, so they cannot feel the stability of the ground. How do you do that? You can make them stand on this tilt board, which actually it's quite hard to balance on it. All right. Or at home, you can do activities like catching ball on a carpet or a foam cushion like this. So at home, I think you would have some foam cushion at home. Make sure that it is deep enough so that you don't feel the ground. All right, so you don't feel the solid ground, and the exercises will help you build up more core muscles and will help you learn how to rebalance yourself without relying on the ground, what you feel from the ground. So recovering postural strategies, you need it. To do that, you need to control the body position and orientation, and this requires motor coordination. Right, your whole body needs to coordinate its movement so that you don't fall down or you can move properly. So how do we do that? Okay, there are three main postural strategies to recover balance during standing. Okay, so postural strategies to recover balance means that if you feel like you're going to fall, there are a few ways you can prevent yourself from falling. You have the ankle strategy, hip strategy, and step strategy. Ankle strategy is where you can actually lean forward and your ankle can bring you back up. Okay, so this is useful if your legs are wide enough apart, and then you can just sway and you won't fall because you're rocking on your ankles. This is in a normal person. Hip strategy is if someone pushes you too hard and you're going to fall a lot more, and this time you will use your hips to pull you back up again. Okay, and then of course if someone pushes you hard enough and then you want to fall forward but you don't want to fall to the ground, you take a step in front too so that you break your fall. Okay, but someone who has vestibular problems or balance problems, they may have problems with their ankle and hip, or even have problems taking their steps. So we need to focus on exercises which help these three strategies so that it will prevent them from falling. So exercises which helps ankle strategy is they can actually at home sway. All right, slight sway, and make sure that the hips and the knees don't move, just at the ankle level. This will strengthen the ankle strength so that if somebody pushes them a bit, the ankles can push them back up again. Okay, then hip strategy, there is maintaining our balance without taking a step, but at the hip level you move. All right, so that you don't fall down. Right, and then step strategy where they shift their weight on their feet. So they need to exercise just taking steps. So one way is to do exercises like this. Okay, stepping over a target or an obstacle so that you build your muscles required to take steps. Now, Sometimes patients may say, I feel like I need to hold a tongkat, perlu pakai tongkat. Okay, it's not a bad thing. All right, a light touch actually provides somatosensory cue, and this is even more important in patients with bilateral vestibular disorders. Okay, because falling down is not good. If they fall down and they hurt themselves more, then it's very hard to, there are extra things you need to rehabilitate. All right, so just by holding the stick, it helps you feel. All right, it tells you this is solid ground. It gives you an extra support, not so much your weight support, but it gives you a sensation that this ground is solid. All right, so I do have patients who say that I feel like I need to hold it. I said, go ahead, but you need to remind them, especially when you see them walking in it. Often they don't really put a lot of weight on it, and after a while, if it hardly touches the ground, means that they have improved a lot. Maybe they don't need it anymore. Yeah, but those who are older, with 65 above or with bilateral vestibular losses, go ahead and recommend these assistive devices, acts as a substitution. All right. This is another aspect. You may find that patients who come to you after many months of vestibular problems, dah pening lama, and they start to have this sakit kat tengkuk. All right, and they walk into your clinic, you may walk like that. Okay, they cannot turn their head anymore. And then they say at the back here, they have this pain and tightness. Okay, because what has happened is over time, they cannot stand the head movements. They become very tense out here so that the head doesn't move too fast, right? So but over time, all this becomes very tense, and that itself can give patients headaches, also dizziness, okay? So it's good to recommend some exercises which helps stretch the neck again. So I would also recommend patients to do stretching, all right? Not too fast, just to relax and pull this up again, up and down, okay? All right. And these are good exercises to do before the VOR or any time that they feel it's tense. Yeah. So loosen back up the neck and the shoulders. So this is also part of VRT. All right. So we've done the exercises to help with gaze stabilization. So your image doesn't shake, right? Doesn't make you feel dizzy. You have enhanced your postural stability, so your body isn't moving too much, right? And you don't fall. So, but some patients still have the vertigo. How can we improve the sensation or the dizziness or the imbalance? VRT can help. Okay. So again, improving vertigo should be the primary goal. I mean, if not, why patient come and see you, right? So this can be achieved by habituation of abnormal vestibular responses to rapid movement. So if you move very fast, they feel pening. All right. So we need to, if we find that it's not a brain tumor or something like anemia, or they have a heart problem, it's something which is a vestibular problem and it's a stable condition, we can help them habituate. So the therapist needs to identify the typical movements that produce the most intense symptoms and provides the patient with a list of exercises that reproduces these movements. So during clocking, we can ask them, what kind of movements make you unwell? Yeah, what kind of movements make you uncomfortable? So sometimes when we are doing the dynamic visual acuity, and the patient have to read like that, and they said, I'm very dizzy, I sangat pening, I cannot do anymore, then you know that that movement is the one which you need to focus on. Okay. So habituation is a reduction in the magnitude of response to repetitive sensory stimulation, which is the head movement. And it is induced by repetitive exposure to provoke the movement. Very jahat. Yeah. Patient already cannot tahan, but we tell them, please do it many, many times. Okay. So habituation is specific to the type, intensity, direction, and of the eliciting stimuli. All right. In most cases, the provoking movement is less frequently executed movement during the daily activities. All right. So what this means that the movement which makes them uncomfortable is actually a movement they don't do every day or don't do often. Because if they do it often, they will have habituated already. Okay. So if they don't have to do it frequently and they know that movement makes them uncomfortable, they will avoid it. And avoidance is no good. That will not help them rehabilitate. All right. So repetition of the originally abnormal signal will stimulate compensation through desensitization. We want them to desensitize. Don't feel sensitive to that movement anymore. All right. If the patient can persevere with their program, most will notice dramatic relief of positional vertigo within 4 to 6 weeks. Habituation effect is slower for the elderly, and the end result may not be a complete success in some patients, but you still try. Yeah. Habituation effect persists for a very long time after application of the stimulus. So it is a form of therapy which works even after you have stopped. So maybe I do this, all right, and I feel a opening skate, but it's shortened. And then if I were to do it again, I feel like, I don't feel it again, right? So one of the exercises we can recommend is called Brans-Daroff exercise. This one patient can do at home. You can teach them how to do it at home. And what it does is you are doing movements which stimulates your semicircular canal, all right? So you ask them to look in front, and then they lie down and look up. Okay, look up in the ceiling for 30 seconds, like in this picture, and then sit back in front again, 30 seconds, and then lie down again, look up for 30 seconds, all right? So if they sit up, lie down, 30, 30, 30, 30, so that's 2 minutes. That's 1 repetition. Normally, I ask them to do 5 repetitions in a row. Okay. The first time they do it, I say do it just before bedtime, before they go to bed. Because after doing it, they may feel dizzy and then they can go to sleep. Okay. If it makes them dizzy, do it more. Okay. Any of the exercises which makes them feel slightly dizzy, they need to see how long the symptoms last. It should last less than 15 minutes. If it goes away after 15 minutes, continue doing it. They should not cause any pain. If there's pain, don't do it. Okay. Now, how else can an audiologist help with vestibular rehab? Okay, I think those with a vestibular lab know what this is. This is a rotatory chair or rotary chair. There is a rotatory chair protocol, which is a unidirectional rotation paradigm. They use the paradigm. Patients with hypofunctioning vestibular system, they sit in a rotary chair with the eyes closed, head tilted 30 degrees down so that our semi-horizontal canal is horizontal, okay? And they spin, all right? Once the chair stops spinning, they open their eyes and they have to focus something in front of them to bring the gaze back to the center, okay? So the direction of the chair is rotated towards the hypofunctioning side. And they go quite fast, yeah, 200 degrees to 250 degrees per second is quite fast, okay? If they can do a full turn, even better, if the patient can tolerate it, and then it suddenly stops, okay? And then they have to open their eyes and stabilize it back again. Okay, this is performed 5 to 10 repetitions if the patient can tahan. Recommended at 2 times per week for 4 weeks. And they have found that it helps in DHI scores, dizziness handicap index scores, helps in posturography results, and also that those who begin therapy early, meaning if they just had their insult, vestibular neuritis, to say within 2 weeks you start treatment, they respond much better or recover much faster than those who come maybe a month after having a vestibular neuropathy. So early diagnosis, begin treatment early is very, very helpful. So I think you all can do this too if you have your chair, right? Slot in some sessions for your patients. Yeah. Okay, the other thing you can do in your clinic is, or in your lab, is optokinetic therapy. Okay, it's been found to be very useful in visual vertigo patients, patients who've got visual dependency. They cannot stand lots of movement. Yeah? Patients with seasickness, patients with unilateral vestibulopathy, chronic vestibulopathy, mild debarkment syndrome, as well as TPD. Okay, so TPD is persistent postural perceptual dizziness. It's a form of chronic dizziness. So sitting in a room with lots of these bars or the lines which you have in your lab will help. But now moving with the times, right? We have virtual reality, right? So simulator-based techniques are now helpful in progressive desensitization, right? give them more movements, give them more imbalanced scenarios, and they will desensitize. So what we can use is instrumental rehabilitation using movable posture platforms. So the platform actually moves. Those with posturography, computed posturography machines, they can do that. Virtual reality techniques to help them, make them feel like they're sitting on a roller coaster or they are on a bicycle. This helps them with habituation. There are other virtual reality protocols which use sensory substitution and sensory feedback strategies, such as electrotactile vestibular substitution systems to rehabilitate patients with bilateral vestibular loss. Because remember, those with bilateral loss, they cannot feel themselves moving, right? But you can actually maybe wear a belt where if you go backwards and they touch the belt, then it gives you a vibration and it tells you to move forward again. All right. So there are belts which help you with this kind of rehab feedback. Now, coming to the last part, which is improving activities of daily living. So the ultimate goal is of vestibular recovery is we want the patients to return to his or her normal activities of daily living. Patients who are unable to return to their normal work and who have this disability to last more than 6 months are actually considered as disabled. But in Malaysia, we don't have this law yet. Even if they want to claim their SOC, so there's no true assessment to label them as disabled. All right, but of course we don't want them to be labeled as disabled, right? So to achieve the final goal of vestibular recovery, the exercises which we recommend to the patient should be integrated into the normal activities, such as walking, rather than just performing the patient inside the house sitting or standing quietly. All right, so various games can be introduced to reduce the monotony of purely remedial exercises. If the patient like to play badminton with their children, please go do that. Want to play futsal, please go back and play futsal. Like to go jogging, please go. Or if you like to do Zumba before this or hiking, please do that. So it has been shown that patients with chronic vestibular loss could still ride a bicycle well, despite having vertigo and imbalance while walking. Or patients who have acute vestibular disorders are better at maintaining their balance when running than when walking slowly. This suggests that automatic spinal locomotor program suppresses the destabilizing vestibular outputs or inputs. All right. So meaning if they are naturally fit beforehand, or they start exercising after that and keep themselves fit, you have your muscle memory to keep you going, keep you balanced. So factors that affect recovery are medications. If you use vestibular suppressants like Stamotil, you will recover a bit slower. But it doesn't mean it doesn't work, just that it'll take you longer time. Those who rely on visual and somatosensory inputs will also delay on or will prevent them from total recovery. So stage of treatment, which is commenced, if they delay their treatment, beginning of the treatment, that will also affect recovery. And how much time you spend on the exercises also depends on how fast you recover. The more you do, the faster you get better. Okay. So symptom intensity does not influence outcome. All right. But if they are constantly feeling uncomfortable and they don't do, of course, it's harder to get better. Lesion site, if it's a cerebellar lesion, then recovery is a bit more difficult. Patient's age, like I mentioned earlier, if they are older, recovery is slower and they may not get 100% better, but there will be improvement. And last but not least, psychogenic factors. So if the patient's very stressed or they got depression and all, or schizophrenia, of course, the dizziness will not fully recover with just VRT. It may help, but not fully recover. So again, VRT must be performed as many times as possible, 2 to 5 times a day for at least 20 to 40 minutes, right? Accepted protocol is about 6 weeks. They should actually get better if they do it every day. But there's some protocols which goes up to 10 weeks. So how do you progress? Start easy, right? Start slowly to what they can do. And then you progress depending on the patient's symptoms. If they say, I tak rasa pening with those exercises, make it more difficult. Okay, make it more difficult for them. And then you need to maintain it. Because there are times if you completely stop moving, just say if you've not been well, kena COVID, have to lie down for 1 week, and suddenly you have to start moving again, you feel not balanced. So you can actually get decompensated. all right? So you need to encourage them that once you feel better, start moving again. So there are special situations where if patient feels very, very sick at the acute period, don't do yet. Let them rest first, right? Once they start feeling a little bit better, please get up and start doing the exercises. If they are nauseous, you may want to give them some medication to stop the vomiting, but you need to see what kind of medication is that, because sometimes it can cause vestibular suppression also. Glasses, good visual input is important, but some of them says when they wear the glasses, they feel even more uncomfortable. Okay, so they can actually remove the glasses for a while until they feel better, then you can put it back on. Safety concerns, if they feel really not stable and they need to do the exercises at home, always make sure that they have family or friends around them so that when they do it, if they were to fall, someone can help them. So, conclusion. VRT works, but requires persistent work. All right. So you can guide them to do it. You can also encourage them to continue to do it if you are not the main therapist. Yeah. As we know, VRT is usually done by a multidisciplinary team, and audiologists play a very important role. Yeah. And how big a role depends on you. All right. So that comes to the end of my presentation. I welcome any questions. Thank you.